Welcome back to NeuroClarity, the podcast that untangles the nervous system one case at a time. I am Honorary Victor, your host, and in today's episode, we are tackling 4 essential neurology cases. We are going to be going from strategic stroke management and brainstem anatomy to the rarely seen but crucial venous sinus thrombosis and how to truly assess stroke risks in atrial fibrillation. Whether you're just a medical student preparing for the boards, a neurology resident in the trenches, or you're just a curious clinician, this episode is packed with practical pearls and evidence-based clarity. Our cases are derived from Ching and Cheng's comprehensive review of clinical neurology. That being said, let us dive into our first case. Question 55. A 49-year-old woman with hypertension on no medication at home presents with TIA, that is, a transient ischemic attack suggestive of ischemia in the territory of the right MCA. Imaging studies demonstrate a 70% stenosis of the right MCA, that is the middle cerebral artery. Based on available evidence, which of the following treatment plans is the best option for this patient? A. Start aspirin. B. Start warfarin. C. Intracranial angioplasty alone. D. Intracranial angioplasty and stenting. E. Extracranial or intracranial bypass surgery. What do you think? Let's zoom out a little. This patient has intracranial atherosclerotic stenosis, which is a high-risk situation. And while many may be tempted to go straight for a procedure, studies have proven that medical therapy is much more superior. The landmark SAMMPRIS trial changed everything. SAMMPRIS stands for Stenting and Aggressive Medical Management for the Prevention of Recurrent Stroke in Intracranial Stenosis. It compared the best medical therapy, that is, aspirin plus clopidogrel plus aggressive risk factor control versus intracranial stenting. And guess what? Stenting was shown to have a highly significant early rate of stroke. Medical therapy included aspirin 325 mg daily, clopidogrel 75 mg daily for 90 days, blood pressure targets of systolic less than 140 or less than 130 in diabetics, a low density lipoprotein goal of less than 70 mg per day, and lifestyle modifications, which includes smoking cessation, exercise, and weight loss. Do you remember the WASIT trial? WASIT stands for Warfarin Aspirin Symptomatic Intracranial Disease Trial. It compared warfarin versus aspirin in the management of intracranial stenosis, and it showed that warfarin provided no advantage over aspirin. In fact, it even had a higher bleeding risk. The bottom line is, for symptomatic intracranial stenosis, aggressive medical therapy is king, and we give aspirin 325 mg daily plus clopidogrel 75 mg daily for 90 days. So back to our question. Definitely, option A is the answer. Start aspirin. Next question. Question 56. A 61-year-old man presents with acute onset diplopia and difficulty using his right hand. On examination, he has left third nerve palsy, right-sided tremors and ataxia, but no choreoathetotic movement. Which of the following is the most likely diagnosis? A. Left hemispheric infarct. B. Left pontine infarct. C. Left midbrain infarct. D. Right pontine infarct. And E. Right midbrain infarct. What do you think? As usual, we are going to break down this question in order to get the right diagnosis. We are told that we have a 61-year-old man who presents to the emergency department with double vision and difficulty coordinating his right hand movement. We are also told that on examination, he has a left third nerve palsy. The eye is down and out with drooping eyelids. He demonstrates tremor and ataxia on the right side, particularly affecting the upper limb. There are no signs of chorea, dystonia, or spasticity. What is the most likely diagnosis? This is is a textbook case of Claude syndrome, one of the classic brainstem stroke syndromes that every neurologist should be able to recognize and localize. Let us decode this step by step. First, we have ipsilateral third cranial nerve palsy, that is cranial nerve number 3. This presents with ptosis, drooping of the eyelid, deviation of the eyes downwards and outward due to the unopposed actions of the lateral rectus and the superior oblique muscles. Sometimes you may have dilated pupils if the parasympathetic fibers are involved. There is contralateral ataxia and tremors, and this affects mostly the arm and the hand. Gait can also be mildly unsteady, and you should note that there is no weakness, neither is there sensory loss, just poor coordination. These two signs together tell a powerful localization story: the ipsilateral third cranial nerve palsy and the contralateral ataxia and tremor. Claude syndrome results from a lesion in the dorsal midbrain tegmentum, specifically affecting the oculomotor fascicle, causing ipsilateral third cranial nerve palsy, and the red nucleus or the superior cerebellar peduncle decussation, causing contralateral cerebellar signs including tremors and ataxia. Why contralateral ataxia? The superior cerebellar peduncles carry output from the cerebellum to the red nucleus and the thalamus. These fibers decussate, that is, they cross at the level of the caudal midbrain, just dorsal to the red nucleus. So, a lesion here affects cross cerebellar outflow, causing contralateral cerebellar dysfunction. Claude syndrome is one of three classic midbrain syndromes, the others being Benedict syndrome and Weber syndrome. Like we said before, Claude syndrome is due to cranial nerve number 3 palsy, contralateral ataxia or tremors, which are cerebellar signs, and these are due to a lesion in the dorsal midbrain tegmentum, specifically the red nucleus and the superior cerebellar peduncles. For Benedict syndrome, we also have cranial nerve number 3 palsy, but in addition, you have ballistic movement, which includes chorea and atetosis. The location of the lesion in this case is the ventromedial midbrain tegmentum. For Weber syndrome, we also have cranial nerve number 3 palsy, but in addition, you have weakness on the contralateral side, and this is due to cerebellar peduncle involvement. There is a lesion in the basis pedunculi which causes Weber syndrome. A cool mnemonic to use to remember this is Claude, C, cerebellar signs; Benedict, B, ballistic movement; Weber's, W, weakness. What causes Claude syndrome? The most common cause is small vessel ischemic stroke of the penetrating branches of the posterior cerebral artery, which supplies the midbrain tegmentum. And less common causes include midbrain tumors, demyelinating lesions, and midbrain hemorrhage. Examples of demyelinating lesions include multiple sclerosis. Claude syndrome demonstrates the beautiful efficiency of neuroanatomy. Just a tiny lesion, perhaps no bigger than a pea, can produce striking constellation of signs, and learning these syndromes allows you to clinically localize brainstem lesions within millimeters even before imaging. Let's pause a little. There is a golden rule that I want you to take to heart. Cranial nerve deficits are ipsilateral to the lesion, and that is because cranial nerve nuclei and fascicles do not cross. But there is one exception. Cranial nerve number 4, which is the trochlear nerve, decussates or crosses within the brainstem before exiting dorsally, meaning a lesion that affects the trochlear nerve will cause contralateral superior oblique muscle palsy. So, back to our question. Our patient has third cranial nerve palsy plus contralateral limb ataxia and tremors, which are basically cerebellar signs. Remember, third nerve palsy plus cerebellar sign equals to Claude syndrome, which is a dorsal midbrain lesion involving the red nucleus and the superior cerebellar peduncle decussation. This lesion is definitely on the left. Remember our golden rule. That being said, option C is the answer. Left midbrain, in fact. Next question. Question 57. A 40-year-old woman with history of diabetes and hypertension presents with severe headache and subsequently has a seizure. An MRV is obtained and is shown in figure 2.16. Let us take a look at our MRV. Which of the following is correct regarding this condition? A. Echocardiogram with bubble study and Holter monitor should be obtained to look for the embolic source. B. Given the history of hypertension and diabetes, further investigations for other prothrombotic causes is not needed. C. A middle ear infection may be the etiologic factor. D. Anticoagulation is contraindicated. And E. Endovascular therapy plays no role in this disease group. Let us take a look at our MRV again. What do we think? Let us try to interpret this image. This is an MRV, that is a magnetic resonance venography, and it is typically used to visualize the cerebral venous sinuses. Let us break it down. In these three views, you can observe the major dura venous sinuses, including the superior sagittal sinus, the right transverse sinus, the left transverse sinus, the sigmoid sinus, and the internal jugular vein. There's an abnormal finding, and if you notice, there is a loss of signal, that is flow void, in the left transverse sinus, seen as an absence or abrupt cutoff of normal bright venous signal. This suggests something we call a venous sinus thrombosis, and in this case, a left transverse sinus thrombosis. On the right side, the transverse and sigmoid sinuses are clearly visualized, and this confirms asymmetry in venous outflow. In cerebral venous sinus thrombosis, a thrombus forms in the venous drainage system of the brain, most commonly affecting sinuses like the superior sagittal sinus, the transverse, or the sigmoid sinus, and patients may present with headache, seizures, visual changes, or signs of increased intracranial pressure. Why is this important? Unlike arterial strokes, cerebral venous sinus thrombosis is less likely to be caused by atherosclerosis, and instead we must look out for prothrombotic states, which includes oral contraceptive use, pregnancy or postpartum states, infections such as middle ear or mastoid infection, cancer, genetic thrombophilias, examples protein C/S deficiency, factor V Leiden, and autoimmune conditions including antiphospholipid syndrome. This patient has diabetes and hypertension, which are risk factors for arterial strokes, but they do not explain the venous thrombosis, and further investigation for prothrombotic or infectious etiology is warranted. Contrary to instinct, anticoagulation is not contraindicated. In fact, it is the first line treatment. Even in the presence of small hemorrhagic infarct, studies show it's safe and crucial to prevent close propagation. And while endoscopic therapy is sometimes an option, it is reserved for severe cases. Think patients with coma, neurologic deterioration, or failure to respond to anticoagulation. I want us to take this away. A missing signal on MRV isn't just a radiologic curiosity, it is a neurological emergency. Always investigate prothrombotic triggers and don't hesitate to anticoagulate. So, back to our question. Our answer is C. A middle ear infection may be the etiologic factor. Next question. Our final question is question 58. A 67-year-old man with history of atrial fibrillation and a recent TIA comes for evaluation. A decision is made to put him on warfarin. Which of the following factors is not routinely taken into account to assess the stroke risk in patients with atrial fibrillation? A. History of diabetes mellitus. B. History of congestive heart failure. C. History of hypertension. D. History of a prior stroke or TIA. And E. History of hyperlipidemia. What do you think? Stroke risk in atrial fibrillation is stratified using the CHA₂DS₂VASc score. And CHA₂DS₂VASc score is an acronym for congestive heart failure, hypertension, age greater than 75, diabetes mellitus, prior stroke or TIA, vascular disease, age 65 to 74, and sex category female. You give a score of 2 if a patient is greater than 75 or if a patient has a prior stroke or a TIA. Else, you give a score of 1. The maximum score one can get is 9. Patients with a CHA₂DS₂VASc score of 0 need no anticoagulation. A score of 1 may require, and a score of 2 and above definitely needs anticoagulation. And if you're paying close attention, you will notice that hyperlipidemia is not included, although it is itself a cardiovascular risk factor. So, back to our question, our answer is option E, history of hyperlipidemia. And that's a wrap for today's NeuroClarity episode. We dissected stroke mechanisms, midbrain localization, venous thrombosis, and the essentials of atrial fibrillation stroke risk scoring, which are all crucial tools in your neurology arsenal. If you found today's episode helpful, you can share it with a friend, drop a rating, and subscribe, or you can even reach out with a neurology question. Until next time, stay curious, stay sharp, and never stop learning. Bye for now.